Hey guys, it's Nick. As promised, I wanted to get you the jaw relation record methodology for mandibular advancement devices. As we talked about in the lecture, this can be a rather complicated arena, and our goal here isn't to get caught in the weeds. So I just want to start with what I'm sharing with you is the best method I could come up with that maximizes the patient's outcome without using a pharyngometer, but is also rather simple. For those of you who want to nerd out and see some of the literature, I'll send it in the email, the comprehensive email that I promised you, which will be done early this week. But for those of you who scheduled the patients this week, I at least wanted to get you the jaw relation records workflow. So first and foremost, we need something round, and there's a series, a bunch of different things in our dental office that we can use that come with different diameters. So I picked a few things. I can promise you that there is a range here, so there's no perfect answer. The Phonetic Bite I had shared with you by Stephen Olmos, he's using phonetics to try to find something close to what is ideal, but that's really more for TMD airway patients. So, and it's a little bit complicated, so I thought that's probably too much for the first jaw relation record. With that said, I'll send you his video if you want to dial that in. With that said, I'm very comfortable with the approach that we're going to take for most patients, in great part because we're going to be able to titrate them later, titrate the appliances after, so if we need to modify them in any way we can. First things first, the patient's overjet dictates the size of the appliance or size of the round tool that we're going to be using, because we're trying to open up the posterior enough to have enough space for the prosthetics. So the prosthetics we're going to use, there's two labs that I recommend. One is NDX and the other is Diamond Orthotic Lab. NDX, the appliance will be cheaper. I don't think it's any less effective at the end of the day. Getting a patient the appliance is the important thing. What we put in there might add to patient comfort. So if you're looking for something cost effective, go with the NDX appliance. I will send some more information on that momentarily. But if you want the ideal appliance, it's the DSO from Diamond Orthotic Lab. But let's just say that whatever appliance we choose, either of those, we want at least 4 millimeters of posterior space. So how do we measure 4 millimeters posterior space? I would imagine everybody has a leaf gauge. If you don't have a leaf gauge, let me know and I can give you some other ideas. Wax works well. But what we want to do is create a thickness that we can put in the patient's posterior segment during the bite to make sure that we have enough posterior space for the appliance to be fabricated without weakness. So leaf gauges, if you have one from Great Lakes Ortho, which is where most of us probably get them, each leaf is 1/10 of a millimeter. So 40 leaves would be 4 millimeters. But if you're curious, you can use a Bowley gauge and try to dial that in, something like this. I'm using a Bowley gauge. I don't think I need to show you guys that. 4 millimeters would be your thickness. And then what you want to do is put that in the posterior of the patient, have them bite down, and whatever size they have in the anterior is what you're going to want to use to select whatever tool you have to best approximate that. It'd be better to go a little bit bigger, but if a patient has a very significant deep bite, class 2 patients, you might want to use something like a cotton stick applicator or a bonding brush, something to that effect, because 4 millimeters in the back might actually just be a little bit in the front. At minimum, we at least want to have a millimeter in the front, okay? Again, there's a lot more to this story. I'm trying to simplify it, but in general, deep bite cases here, everybody else back here, saliva ejector will probably get you there, or a surgical suction. You can either use this tip here, or just find something round. And the reason we're using something round and not the leaf gauge, I do use the leaf gauge quite often, but you're safer using something round because if there's a cant in the mandible during an MIP, we want to undo the cant from a neuromuscular perspective. By putting something round, it gives the muscles the opportunity to find a sweet spot neuromuscularly, which decreases the tonality of the muscles in the head and neck, which does help the airway. So I would imagine most of us with class 1 patients that have normal overjets and overbites, we're going to use a saliva ejector. Okay. So what we're going to do is have the, double check here and here. For me, I'm pretty darn close to this being the ideal. That gives me 4 millimeters out back. Now, we talked about the fact that the vertical could be opened, and we used the pharyngometer to find the optimal opening. I'm choosing this based on averages. I find anywhere between 4 and 6 millimeters for a normal class 1 patient's is ideal. 4 to 6 millimeters from edge to edge. Now, 4 to 6 millimeters edge to edge in a class 2 deep bite case might actually be open 12 millimeters. So you can see where this gets a little bit convoluted. With that said, by using this set of leaf gauges, we're approximating 4 millimeters in the posterior, which should get us right to where we need to be, regardless of how thick or how tall or vertical it is in the anterior. Once this is in the front, that's it. The muscles will do the rest. They're going to balance that by having the muscles fine-tune that rotational aspect of the round object. The muscles are going to find a bilateral harmony, which is going to be neuromuscularly optimal for that position for the mandibular advancement device. Now, what I haven't shared is how far forward we're going to go. Have the patient come edge to edge when you do the bite. Okay? We're going edge to edge because we want to decrease the amount of protrusion we have or protrusion we need, because we know the vertical component through some studies is actually more relevant or just as relevant as the protrusion effect that we once thought was necessary for maximum outcome with mandibular advancement devices. So let's start edge to edge, and once the appliance is made, we're going to have the opportunity to titrate through using different elastic bands. So if the patient doesn't have the effect that we want, we can switch out the bands every so often until we get that protrusion to where we want it. The alternative is we spend $30,000 on a pharyngometer to find that mandibular position like we did when Rebecca was giving us the demonstration in class. But I don't think we're going to do that for this beginning of this exercise. So in a nutshell, this is the simplified approach. We're not even going to do the phonetic bite. Again, that opportunity is there for you. It'll be in the email. This is a simplified approach that basically says, look, if your patient's relatively close to average, we're going to get an outcome that's subjectively noticeable by the patient by improving their AHI. As we move forward, if we want to get more granular with it, I'd be happy to help you. There's lots of courses out there, and I'll direct you guys where you need to go. I just ask that you understand what I'm sharing with you was a highly simplified, filtered approach to try to get you guys to get the homework assignment done, but also dip your toes in the water of this awesome aspect of dental medicine. All right. So if you have any questions, let me know. And I appreciate all of you guys who are going to embark on this journey. If you have any questions, I'm an email away. toothdoctor17@gmail.com. Take care, guys.